It's a little hidden secret in every health system, which is in the United States, health systems spend between $10 and $15 billion a year manually abstracting data to populate registries. The people doing the work are highly skilled nurses that should be taking care of patients, but instead they are manually going through different systems to extract data, make a clinical inference about what that data means, to then populate a registry system over here. Yeah. And so we call it swivel chair interoperability, where they're literally doing this all day long. And it's costing the United States healthcare system, billions of dollars every year. So it's an important problem to solve for.
Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change.
All right, we're live at ViVE. Greg, thanks for stopping by.
Hey, thanks for having me.
Yeah, another edition of the Boombostic Health Podcast here in the Diagnostic Zone. And we're thrilled to have Greg Miller, VP at Carta Healthcare. And you have a unique position relative to being a marketer like myself when you think about, okay, there's a lot of noise out here. There's a lot to kind of get through and cut through. But before we get to that part of the discussion, tell us about Carta and what you do.
Sure. Maybe start with the problem.
Yeah, let's start with the problem.
So it's a little hidden secret in every health system, which is in aggregate in the United States, health systems spend between $10 and $15 billion a year manually abstracting data to populate registries. And the people doing the work are highly skilled nurses that should be taking care of patients, but instead they are manually going through different systems, mostly the EHR, to extract data, make a clinical inference about what that data means, to then populate a registry system over here. And so we call it swivel chair interoperability, where they're literally doing this all day long. And it's costing the United States healthcare system, billions of dollars every year. So it's an important problem to solve for. The downstream use case for registries is really quality and process improvement. And so you need highly skilled people and highly accurate data to populate the registry, because then it gets commingled with many other hospitals that participate in that registry. And some registries are mandatory, like CMS core measures, for example. Other registries are voluntary, and usually they're sponsored by the medical societies, like the American College of Cardiology, for example. Right. And so, but it's also, the downstream use is for accreditation of their programs. It's for, again, quality and process improvement. It's for, in fact, star ratings, quality benchmarks, lots of different uses.
So when we talk about uses, and you and I before came on talk about kind of human in the loop, right, relative to ensuring that the cleanliness of the data is pure and as pure as it can be, right? So tell me kind of from that lens how you think about it.
So registry work is highly specialized,
right?
And so, for example, there's individual registries that want to measure quality for cardiac cath procedure, right, type cases. And so to really understand the question being asked, like, for example, let me just give you an example. So I'll take cath PCI as an example.
Yeah. Okay.
And so there's a question in there, does the patient have cardiomyopathy? And it's a yes/no question. And so nowhere are you going to find in the patient's record that it says the patient has or does not have cardiomyopathy. It's a combination of a ton of different data elements. And that's why you need a clinician to be able to understand the data elements, to then answer a question over here, yes or no. Okay. And so it would be great to be able to just apply AI to the challenge and have fully autonomous AI. One thing we know from our customers and from the market in general is there's still a lack of trust, right? There's belief and there's hope, but there's still a little bit of a lack of trust. At the same time, for somebody to be able to, understand what the registry question is really asking, you need that clinician oversight. And so we've got about 300 clinical data abstractors on staff that are actually our product development team. And so we have engineering, obviously, but it's our abstractors that say, hey, this is how the product should work. This is what these questions mean. These are what types of data needs to go into the system in order to calculate the answer. Yeah. And then at the same time, the registry bodies themselves don't allow automatic population of the data in the registry system. They want a clinician to look at the results, the AI results, and say yes, no, or what have you. And so, today we probably automate, depends on the registry, because some registries are super complicated, some are easy. But we probably, from an accuracy perspective, out of the box, we're at about 90 to 95% accurate.
Okay.
But we still need somebody to validate that that is the right answer.
Right.
We recently ran a market survey, and it was quite interesting. And it's still running, actually, but I'm watching the results come in. And 100% of the respondents have said that AI has to operate with clinician oversight.
Yeah.
So it was just a good metric to see, to validate that our approach is on target.
Yeah, and I don't think we'll find much disagreement with that, right? That AI is certainly a powerful augmentation tool, but clinician oversight, unlike other industries, even some regulated industries, you have more leeway and flexibility with the way that they can leverage technology. But because we're dealing ultimately with people and patients, there is definitely that impetus, especially as technology continues to evolve, right? In order to kind of have that human in the loop, as we've discussed. What's fascinating from a practitioner perspective, though, when you think about, okay, how do we talk about all this, and how do we kind of sell it in and gain that buy-in at the hospital system level? What's been kind of your finding as a marketer and executive and business development in the commercial side? What's stayed the same recently? What's might have changed?
Yeah. So, quick story.
Yeah.
So
absolutely.
roll back a year ago, and we needed to rebuild our website. As part of that, we had to really deeply think about the positioning of the company, right, and the messaging and all that sort of stuff. And so I was just super deep with lots of different people inside and outside the organization, trying to understand what is our unique differentiation. And so I should mention, we've been applying AI to this challenge for 10 years. So this is not new to us.
Right.
LLMs are newer to us, but NLP and machine learning in the previous incarnation. Anyway, so I was meeting, I knew that we had state-of-the-art AI, and everything we do is built on Claude. So we get the benefit of Anthropic's billions of dollars in investment.
Yeah.
But so I was meeting with our clinical teams and our clinical leadership, and I was like, you guys got to really help me understand what makes us different. And at the end of that conversation, I was thinking about it for a while. I'm like, so it's really not artificial intelligence, and it's really not just clinician oversight. It's a combination. And I was like, it's really hybrid intelligence. And so I thought it was pretty cool. And I came up with some new term, but then I Googled it, and quite literally 2 weeks before, Forbes had published an article on hybrid intelligence. And then McKinsey, through their quantum black practice, also was talking about hybrid intelligence. We're the only one talking about it in that term in healthcare, but that was the genesis of the repositioning of the company. And I should say, it wasn't new. That's the thing, right? We always had that clinician expertise and oversight.
Yeah.
And so in the marketplace, what we know also a year ago or so, there were a bunch of AI startups that were trying to get into our space. And they caused some noise because they had, they were touting all their AI muscle. And so we don't tout our AI muscle because we are experts in the abstraction space. Yeah. And so it causes some challenges from a sales perspective for a little while. But then it became very clear to us from meeting with potential customers and our existing customers that when we talk about hybrid intelligence and clinician oversight, it's just, you see it in their eyes. Yeah. It's absolutely a requirement. It's not an option, right? So I think that dynamic has settled down now. And I think the overall, they're not chasing a shiny object as much. What they're really trying to do, and health systems tend not to buy technology for technology's sake, right? They buy solutions that solve a very specific problem, and that's where we sit in the market.
So maybe dive in a little deeper into hybrid intelligence.
Yeah.
Right. When you think about that word, and it could be used broadly, but you're using it in a very kind of myopic sense. What is it? How did you come across that term relative to your specific business? And then when you think about the application of that, from kind of a product value proposition perspective, what does it mean?
Sure. So I thought I invented the term hybrid intelligence. It's just literally, it's what popped in my head when I was meeting with our clinician leadership. And I've never really been comfortable with the term artificial intelligence, because artificial means fake. Yeah. So what are we really trying to get at here? Yeah. And just knowing the complexities of registries and the clinician in the loop is always important. What we evolved to is we have a top-notch engineering team, and but they don't know what to build unless they're told by somebody, right? You need a product spec. Well, who's the best at defining what that product spec is?
Right.
It's our clinical teams that do the work every single day. And when we meet with customers, it is immediately apparent to them that our clinical team, who does the same work they're doing every single day, has designed the product. And that's just a continuous evolution. We'll push out new product, new features all the time, and that's based upon clinician feedback.
Right. So obviously, you're here. You guys have a booth presence too. When you think about what's exciting, what's new, what stood out to you?
I've been doing this a really long time, about 40 years, and every year, whether it was HIMSS or whatever show, we always play this game of, okay, let's walk around. What's the word that's on everybody's booth? Right. And last year was AI.
It's on the bingo
right?
card. Yeah.
Exactly. And so it still is a lot of AI as you walk around here. I think of course, AI is hot. I think we're getting beyond and I think about the hype cycle kind of thing, right? I think we're getting beyond AI as a thing. Yeah. Right. AI is just embedded. Like, back in the .com area, right? It was super cool to have .com after your name and have it printed at trade shows on the back of your collar. That went away, and so now just in e-commerce, for example, is just another channel. It's not anything unique in and of itself, right? Unless you're Amazon. Yeah. So I think we're starting to see that we're beyond the shiny object phase, and people are now really looking for return on investment. And I think in healthcare today, C-suite executives are looking for a return on investment in 6 months, no more than a year. Right. Our ROI starts on day one, literally on day one. Yeah. But I think that's the essence. So while you may have had a year ago a lot of shiny objects, a lot of cool solutions, things like that, I think it's starting to sort of boil it all down to the real solution providers.
Yeah, and there has to be the practical implementation, right? It has to, be able to be incorporated into workflows. Has to make sense, within the regulatory environment, right? It has to fit within the current policy constraints that are out there, and it has to support the economic value proposition, right? That's truly the three-legged stool that a lot of this technology has to sit on.
For sure. What we also find is critically important is it has to be incorporated into the workflow. Right. So if it's outside the workflow, it's an extra step, it's an extra thing, an extra tab, or an extra button, or a new app. It doesn't fly. Yeah,
I think, I do think we are on the right path, and I think this wave of technology, I think the last 5, 7, 10 years, there have been, let's add great technology, but it increased the workload and ultimately stood outside many times the workflows.
Sure.
I think now with agentic AI and being able to integrate into the large EMR systems, and being able to do so effectively, I think is going to ultimately reduce that burden, which we've all been yearning for a long time. Sure. But I think hopefully this technology is here at the right place to allow us to do that.
Yeah, and I think a year ago we were still hearing a lot about the trust issues, right? Yeah. Is AI going to take my job? And I'm afraid of this. And that has simmered down. Yeah. And now people are the number of people that reach out directly to us without us having to pull them in has just dramatically increased in the last 3-4 months. Yeah. So I look at those signals in the market for where the market is generally with adoption of new solutions, especially AI.
Yeah. Okay. Awesome. Well, thanks so much, Greg, for stopping by. We appreciated the time today, and continued success to you guys.
Likewise. Thank you.
Thank you.